Again, welcome to our December edition of Controversies in Cardiology. I'm Marty Goldman. Just a few announcements. In the next few sessions in January, we will have Dr. Smoulakis from UCSD. In February, Dr. Rahal from Mayo Clinic. March 23rd, Dr. Mahaffey from Stanford. In April, Dr. Sid Smith from University of North Carolina. In May, Sam Goldhaber from Brigham and Women's. And in June 2015, Dr. Paul Armstrong. Because this is holiday season, we're giving everyone a special present this month. There's a special controversies that we're going to have broadcast on heart-talks.org, where you can see our current program, and that's going to be a very exciting talk on mitral regurgitation. That's going to be 7:45 next Monday. It's going to be live from this auditorium. Dr. Sharma is going to moderate a panel, and we're privileged to have a tremendous panel. Dr. Fuster, Dr. Adams, Chief of Cardiothoracic Surgery, Dr. Carabello, Dr. Gopalan, Dr. Meller, and Dr. Sengupta. Those people who were waiting to attend Dr. Fuster's consultant's course in December, unfortunately you missed it. You may have been among those who, of the 2,000 who attended. Book early for next year, but it's one of the highlights of the year for the American College of Cardiology, and that just happened this weekend. I didn't expect Dr. Fuster to be ready, but he's going to appear on the panel. We're very lucky that the panel will be moderated by Roxana Moran, and let me just tell you a little bit about her. She's Director of Interventional Cardiology Research and Clinical Trials here at Zena and Michael Wiener Cardiovascular Institute, Mount Sinai School of Medicine, Mount Sinai Heart. She's internationally recognized for her work as a clinical trial specialist with complex data analysis, outcomes research within the field of interventional cardiology. She's on many prospective trials involving new technology and techniques in interventional cardiology. She's been the course co-director of the annual Transcatheter Cardiovascular Therapeutics, TCT, of the American College of Cardiology the last 15 years. She's also the Chief Scientific Officer of the Clinical Trials Center at the Cardiovascular Research Foundation here in New York City. We were very lucky that the topic that we were interested in, really one of the hot topics in cardiology today. Both Roxana is an expert, and so are all of our panelists, and especially our visiting professor that Dr. Fuster will introduce in a few minutes. But before we start, we're going to have Sandeep Gangredi, who's one of our cardiology fellows, give us a brief preamble on the subject. Sandeep?
Thank you, Dr. Goldman. Ladies and gentlemen, welcome. I just want to thank you for allowing me the opportunity to talk to you today. Before we begin, I just want to say a quick thanks to Dr. Hladky, our visiting professor, and Dr. Roxana Moran for agreeing to be our moderator. Our topic today is dual antiplatelet therapy in coronary stents, with a particular focus on the optimal duration of therapy. Since its invention, PCI with coronary stent placement has been limited by restenosis and vessel closure due to early and late thrombosis. And although the use of drug-eluting stents has been shown to reduce the rate of restenosis by about 70%, the risk of stent thrombosis remains. Now, the prevalence of stent thrombosis is quite low in patients who receive a drug-eluting stent and dual antiplatelet therapy, being around 1% per year. However, stent thrombosis carries a high risk of MI and a mortality risk of up to 45%. Now, stent thrombosis occurs in specific clinical and angiographic predictors. For example, diabetes, renal failure, acute MI, in cases of suboptimal stenting, bifurcation lesions, multiple stents, and uncovered injury segment of diffuse lesions. However, premature discontinuation of antiplatelet therapy is thought to be the main cause of stent thrombosis. Dr. Moran and Dr. Baber actually led a study in the Paris registry that examined 5,031 patients who underwent PCI and it was revealed that over 2 years of follow-up, the incidence of any dual antiplatelet therapy cessation was 57.3%. The rate of discontinuation was about 40.8%, and interruption was 10.5%. And other prospective studies have shown that up to 29% of patients who underwent DES placement and stopped dual antiplatelet therapy prematurely developed stent thrombosis. So again, a very critical issue. Now, we all know that dual antiplatelet therapy with aspirin and a P2Y12 receptor blocker is a standard regimen for preventing atherothrombotic events in patients who have undergone PCI with stent placement. And current guidelines recommend dual antiplatelet therapy for a minimum of 12 months following stent implantation, depending on specific device and clinical factors. More recently, several trials have investigated both shortening duration of dual antiplatelet therapy to 3 to 6 months, as well as prolonging therapy beyond 1 year, specifically looking at the changes with next generation DES implantation. In terms of shortening dual antiplatelet therapy, the excellent trial evaluated patients receiving a next generation Xience Promus stents in groups at 6 and 12 months of dual antiplatelet therapy and demonstrated no statistically significant difference in the primary composite endpoint at 4.8 versus 4.3%, or in terms of TIMI major bleeding between 6 and 12 months of dual antiplatelet therapy. Similarly, the RESET trial evaluated safety and efficacy endpoints in dual antiplatelet therapy at 3 versus 12 months following Endeavor's Otaro-Limis stent implantation. And again, there was no statistically significant difference in their primary endpoint at 4.7% across both groups. In terms of trials looking at extending dual antiplatelet therapy, I'm going to group these together, but there was the Real Zest late study that looked at dual antiplatelet therapy for 12 versus 24 months, the Prodigy study looking at 6 versus 24 months, the Arctic Interruption study at 12 and 30 months, and the Italic and Italic Plus study at 6 and 24 months. And interestingly, all of these studies did not show a significant difference in their primary composite outcomes, and only the Prodigy study showed a significant difference in terms of major bleeding at almost double the risk of major bleeding. The Arctic Interruption study showed a trend towards an increase in major bleeding, but also that was not statistically significant. Now, the study that flies in the face of all of these is the most recently presented at AHA by Mari et al. The DAP study was presented and looked at a composite co-primary efficacy endpoint of stent thrombosis, death, myocardial infarction, or stroke in patients receiving dual antiplatelet therapy with clopidogrel or prasugrel at 30 months versus 12 months. And in this case, dual antiplatelet therapy compared with placebo reduced the rates of stent thrombosis in terms of 0.4% versus 1.4%, and major adverse cardiovascular and cerebral vascular events, 4.3% versus 5.9%. Notably in the study, the rate of death from any cause was higher in the group receiving extended dual antiplatelet therapy at 2.2% versus 1.5%, although this was thought to be primarily related to cancer-related deaths. Also notably in the study, there was an increased risk of moderate or severe bleeding, which was statistically significant at 2.5 versus 1.6%. So with that, I think the question before the panel today is going to be, how do we find the optimal balance in terms of reducing ischemic and bleeding risk, and which patients, if any, should be targeted for extended dual antiplatelet therapy? And with that, we'll have Dr. Fuster come up.
Thank you very much, Sandeep. This topic is a torture.
That sums it up.
It's a summary. Very difficult, but anyway, it will be a good discussion. Most importantly, let me introduce the visiting professor today, a very close friend and associate editor of JACC. We talk every week, and a very excellent reviewer and with a fantastic judgment. Dr. Mark Plotke. He obtained a medical degree at the University of Pennsylvania, first at college at MIT, and then he has his internship and residency in internal medicine at the University of Arizona at Tucson. Then he spent a year as a clinical scholar, Robert Wood Johnson, clinical scholar at the University of California in San Francisco. And then he went to Duke, where he had his cardiology fellowship. And then at Duke, he spent a few years and as an associate in medicine, an assistant professor. And then there he was the associate director of the Duke data bank for cardiovascular diseases, probably the most prominent data bank in the country at that time. Then Dr. Hladky moved to Stanford, where he was associate professor of health research and policy, and then professor of health research and policy, professor of medicine. And there he was the director of the Donald Reynolds Cardiovascular Clinical Research Center and director of the Stanford Kaiser Cardiovascular Outcome Research Center. Now, meantime, he spent some time, interestingly, during this period that I'm mentioning at the Stanford, he spent a time, perhaps a year, at Jackson Laboratories in Bar Harbor, studying genetic approaches to complex heart, lung, and blood disease scores. Now, eventually, he really moved academically, scientifically, and on many, many areas, all successful. Let me say, to start with, that he has significant awards. The most recent one was the Distinguished Scientist Award of the American Heart Association, actually, in 2014. And this is preceded by other outstanding awards. Now, he has been in the editorial, with editorial activities, as I mentioned, associate editor of the American College, of the Journal of the American College, and then editor and the editorial board of the American Heart, Cardiac Electrophysiology, Circulation, etc. Now, in terms of advisory committees and then on clinical guidelines development and other aspects, yeah, I have to tell you, is quite impressive. He has been in the advisory committee in the state of California, the California Health Policy and Data Advisory Commission, Harvard University Center for Risk Analysis, at the University of California, chair of the Scientific Advisory Committee, Blue Cross and Blue Shield, Washington University, National Heart and Lung Institute, Strategic Planning Working Group on Heart Failure and Cardiomyopathy, as well as Working Group on the Standardization of Lipids, Lipoproteins, and others. And then in the Centers for Medicare and Medicaid and Institute of Medicine. I mean, he has really been in the cutting edge of all the key institutions in the country. In guidelines, he has been part of 7 guidelines that came out with the ACC and AHA in the last few years. And then where he has been very active is a Data and Safety Monitoring Committee, as well as in multi-center randomized trials, having key positions in all these different entities. Actually, I counted 17 with key positions, and certainly the chair of the monitoring committee in a number of them. Now, he has MESHA grants. I counted at least 11, 12, 13, but I would mention NHLBI, Cost and Quality of Life Outcomes, after PTCA or CABG. NHLBI, Stanford Clinical Research Training Program, K30. He has been the chairman of the Donald Reynolds Foundation grant for Stanford. And then he has another grant in NHLBI, Economic Outcomes of Treatment Strategies in Bari. And it's interesting, so his bibliography, he has about 350, 400 papers. But what is interesting is the fact that he has been involved in almost any entity in the cardiovascular field. But the question is how. And he has a number of very interesting observational studies, participating in trials, and certainly very involved in outcomes research. So he really knows, he has a view of the cardiovascular field, which is quite pertinent today. And I just mentioned his first paper is interesting, is in 1981, is plasma cholesterol. Can it be too low? You were already into that business at that time? What was your answer?
It was okay.
It was okay as it at that time was too high though.
Yeah, well, the worry was cancer. Whether we could cause cancer or there was a cancer problem with these two.
Oh, interesting. Yeah, this lasted for a while actually. Yeah. Well, anyway, thank you very much for having you here today, Mark, and let me give you a plaque to remember your visit, which apparently was, you gave a fantastic talk. I'm sorry I couldn't be there this noon, I was told. Well, our faculty express appreciation to you for outstanding teaching, wisdom, and expertise as the Anandi Sharma visiting professor. This is the father of Samin, and the Simon Duck Memorial Lecture, December 15, 2014. Thanks for coming.
Thank you.
I give you this. Okay. I'm sorry I don't have the list of experts, so can you, you have it? Okay, you can sit here in the middle.
Can you join us, Dr. Foster? Thank you,
You
yes.
sit here in the middle.
If I can ask
That's why I
Dr.
can get it from
Baber,
both
Dr.
sides.
Sharma,
Then you-
Dr. Dunsky, please. We'd like you to be here as well.
All right.
Dr. Dunsky, please. Wow, and Dr. Baraman, of course. Well, first and foremost, I want to thank everyone, and especially
It's okay.
Dr. Goldman. I want to thank you, Dr. Goldman, for inviting me, as well as Dr. Fuster and Dr. Sharma, for asking me to moderate this, this fantastic session, I think. And for those of you lucky, I think if you weren't confused beforehand, you might be very confused at the end.
Don't say
So I want to start actually with Dr. Latke. Dr. Latke, thank you very much for being here. We really enjoyed having you today. The fellows really enjoyed the time with you, and your lecture was outstanding. But given what we know now, and you knew we were going to talk about this, I really want to hear from you firsthand. What do you think about what's going on with DAPT duration as a whole? And where do we stand today based on all the trials that we have? If you could, in a, not to take very long, but in a sort of a nutshell, where do you stand on this whole topic?
First of all, let me just say thank you for the wonderful time that I've had here. Everybody, the hospitality has been terrific, and I'm enjoying being in this wonderful place and seeing all the wonderful things you're doing. You know, I have a few points of view, and it may be, for better or for worse, I like to read the things myself and come to my own conclusions about all of this. And I think one of the interesting things is trade-offs. Is ultimately the issue here, because my reading of the literature is that there's no doubt that that dual antiplatelet therapy compared with just aspirin alone reduces cardiovascular events after drug-eluting stent implantation, but it also reduces them not after it. It reduces it in general, and it reduces it in vessels that didn't have a stent. So there's a general thing, and then there's a specific thing for the stented area. And the other thing is there's no doubt that taking 2 antiplatelet agents is going to cause you to bleed more than if you took 1. And so the real question is where's the risk-benefit balance come back into play, and does it flip the other direction? And you know, I think trying to sort that out from the data is difficult, because I think the risk of stent thrombosis goes down over time, but the risk of bleeding continues. And so at some point, the intuition is that there's going to be a tipping point, and we're not sure where that is. And I think from a methods point of view, one of the things that's a common theme in everything that Dr. Fuster was talking about is I'm very interested in the methods of how we know this stuff. And you know, it's very hard to do studies to judge duration, and this is one of the very few ones where we figured out how long it is that we need to treat people. And that there have been a few trials. They've not been exactly the same, so they're kind of hard to put together. But you know, my reading of it is there's a cardiovascular benefit that continues, probably goes on for a longer period of time. But there are risks too, and you know, in some of the studies there are signals that suggest that all-cause mortality is in fact, if not reduced, even increased. So I think we have to be concerned, and I'm not sure in the end that we're going to have a clear-cut answer.
Yeah, so we're going to get to that mortality piece, because I do think it's quite important, and we do have to talk about that. Dr. Fuster, what did you think about how Dr. Latke reads over this? What do you think? I mean, you held a beautiful session at the American Heart Association at the cardiology show. You discussed this. I know you've had a lot to think about this. You think it's torture. Tell us, what do you think? Where do you stand on this?
No, well, basically, all the studies in the last 2 years that have been published, actually, you can see what exactly Mark mentioned is a benefit with dual antiplatelet therapy. There is a risk of bleeding, and the question is when you stop the 2 drugs and you just give one. And the studies tend to suggest, most of the studies, that you can stop one of the drugs at 6 months. Some studies may suggest 1 year, and more recently even 3 months. So the question is then, how do you put this together with the recent DAPT study? And the way I put it together is, first of all, the DAPT study had 10,000 patients. The others have 1,900, and there is a different power. And then the others, many of them had as an endpoint the combination of cardiovascular events, including bleeding, where the DAPT separated bleeding. So the whole issue of DAPT is great in preventing cardiovascular events, and actually in the native circulation, not necessarily in the stent. But if you add bleeding as an endpoint, the results are very equivocal. So I think the question, that's the way I interpret all of this.
Mm-hmm. And it's all about what matters to you more, right? Is it bleeding or is it stent thrombosis? Which one is more important? Dr. Sharma, you put in stents every day, many of them. You think now that all your patients are going to be on dual antiplatelet therapy forever? And I know that you told me today you were very impressed about the curves after the stopping from 33 months to 36 months, where Laura Murray actually did look at that. There was an observation period beyond the time that the dual antiplatelet therapies were stopped. So tell me, what do you think? What should be our take-home message from an interventionalist perspective?
Well, knowing that it's clearly a very controversial issue and a statement everybody will make, basically try to justify own's practice. But since the publication and of course a lot of news in the lay media, the physicians and patients, many have called, many of them who have stopped Plavix almost 6 months ago, asking whether they should restart, should take it for 3 years. So this has really created a lot of confusion, because in last few years, we as an interventionalist are working that can we decrease the DAPT duration. And we thought that until now, that we won this battle. Because every trial, whether we compare from 6 months to 24 months in Prodigy, then we said, and others from 6 months to 12 months, and even then 3 to 12 months, showed that decreasing the trial duration of the DAPT does not harm. Rather, longer duration may have a little more bleeding. So this has come to a total surprise. And some people just feel that, it may be related to only secondary prevention of the cardiac event. Well, it may be. But if you just go with the trial, there was absolute 1% decrease in stent thrombosis from 1.4 to 0.4. Now, the biggest issue from that I'm not changing that's your basic question, is that based on the DAPT study, are we going to change our recommendation? So reason being is that what DAPT does not answer, and that's a very relevant question, that does it really decrease stent thrombosis in the current generation of our second, third generation stents, which is particularly everolimus eluting stent, which actually the data from Usman Babar and Dangas have shown, and many other trials, that has the lowest stent thrombosis. And actually in the United States now, that is the #1 stent. In the study, it was 47%. So we don't have a breakdown of the event rate in that particular group of patients. So having not really convinced that in that particular stent group, this rule of the prolonged DAPT will apply, we continue. I would say personally, my message to all our referring physicians, our own practice in the institution, and the patient is continue what we have been doing so far up to 1 year.
So don't change anything until we have this other thing. But is it all really about stopping, or is it about interrupting therapies as well? I mean, there is a very, very important question regarding a mandatory period. What is that mandatory period to protect the patient against a stent thrombosis that is due to the stent? And why do we have to have the dual antiplatelet therapies on board? What is that length of period of time? And Dr. Fuster did tell us about 3 months. In certain studies have looked at that, 6 months, all of them underpowered, versus a longer period of time. And Kevin, you take care of a lot of patients, and on a daily basis, you have to deal with these patients going for surgeries and being referred for, you know, all kinds of non-cardiac procedures. What do you think, based on everything that you know and your own general practice, the most common question and how you handle it every day? And has that changed based on all of the studies that you have seen?
I think it's changing every day,
Mm-hmm.
essentially, and I think as Dr. Sharma said, for the past few years, it's really been how low can we go? Can we go to 6 months? Can we go to 3 months? And that's where our referring surgeons and colleagues and preoperative decision-making, even in terms of when we send someone to the cath lab, what type of stent, and if it's, let's say it's going to be a transplant where we're looking out 6 months to a year, will that affect what we do or how we do it? I think in looking at the study, I think the fact that bleeding was kind of pushed to the side it was obviously a major factor in there. I think where it comes down to, in terms of more of from a preoperative aspect, in those settings of patients, I think for right now it's using the clinical cardiologist, maybe an art that's not as in favor in terms of seeing who the patient is, what the surgery is, where things are. It's not very satisfying because we've got people who can mold the data to whatever answer they want to have going into the decision-making process. I think for me, generally it's about, right now, I'm keeping it about a year unless there's something urgent. I'll feel comfortable doing it at 6 months if need be, if it's urgent. And if it's not, if it's elective, I would probably push it out.
All right, well, that sounds good. Dr. Bataman, you could have done so many incredible studies on the pathobiology of our vessel wall, how the platelets are functioning, what's going on when we have dual antiplatelet therapies on board. How do you put together the DAPT study or all of these studies? Do you believe that the stent is playing a role, or is this about the patient and the demographics and everything else that's going on in the patient, as far as everything that you know from your laboratory and all the incredible work you've done?
I will tell you my feeling when I was sitting for 2 hours in the American Heart, and after listening to one trial, I said, 3 months is enough. After listening to the other, I said, 6 months is a little bit better. And then I saw the DAPT, and I saw that you stop it, and 30 months later, there is a bump in death, okay? So, and then I look again, and I saw that in one of the studies, they say thiopyridines, but they use prasugrel and clopidogrel. In the other, it started 9 years ago, and they were using a combination of stents and a combination of patients. So after 2 hours and a half, I left the session without knowing anything new. And going to your question, I will say that I don't have patients, but I can tell you what I will do if I was a patient. So obviously, I will use one of the newest stents, and we don't know what we have to use. I will use one of the newest and more potent P2Y12 inhibitors. And if I am the lucky one that I don't bleed, I will take it dual antiplatelet therapy, probably for a year. And again, if I don't have bleeding, I will take it longer, because we know that in secondary prevention, an intense antiplatelet therapy works. If you bleed, it's a problem. Then you have to cut it, because if I bleed a little bit, even though bleeding is not death, probably not me, but another patient will stop taking anything. Mm-hmm. And then you will have an stent thrombosis. But I think that after 2 hours and 30 minutes sitting there, I didn't learn too much. and I end up living with my own ideas that I have, that this is what happened to all of us in the panel.
So Usman, I'm going to put you on the spot a little bit because I think you know that you've done a paper on the differential events in patients who receive newer generation DES. This study had a 53% older generation DES. I know myself that you're working on a big paper, so I know that you've done a lot of work on understanding this whole idea of numbers needed to treat, to gain the benefit as well as harm. Tell us, what do you think about, and the fact that there was the P interaction test was negative, and maybe you can explain that to everyone in clinical terms, what that meant for the type of stents, and what your takeaway is from this study.
Thanks, Dr. Moran. So, I think one common theme that's come from everyone up here is that at the end of the day, what the DAP study did, I think, is probably affirmed preconceived notions. So those people who felt we should prolong have argument in favor of that. People who felt, well, we can probably stop a little bit early, found arguments and data to favor that. And one way to try to get at some context, because at the end of the day, we want to find risk-benefit ratios, or how do we put some metric that lets us know whether or not we're helping or hurting our patients in a net way. And one way one can do that is look at the absolute event rates. So in the overall DAPT study, provision of DAPT did result in about a 0.9% absolute reduction in stent thrombosis, and the risk increment in bleeding was about the same. In other words, for every stent thrombosis you prevent, you cause one gusto moderate or severe bleed, which is not a benign bleed, by the way. Those are really large bleeds. If you look at the patients who were given everolimus-eluting stents, and as Dr. Sharma mentioned, not too many patients, but there was enough for some calculations to be done. In that population, the absolute reduction in stent thrombosis was 0.4%, so much less. However, the risk in bleeding was about the same. So in patients treated with newer generation stents, for every stent thrombosis you prevent, you're going to cause about 3 major moderate to severe bleeds. So that's at least one way you can try to help personalize or maybe contextualize the decision making. So in the new generation era, even from the DAP data, you can find that the penalty you pay by extending DAP is actually much larger than the newer generation, the earlier generation devices we were using, and essentially we don't use anymore. There was some, as you mentioned, Dr. Moran, there were, in the primary paper, they did make this point that there was no quote-unquote interaction, meaning that the benefits or harm of dual antiplatelet therapy were uniform. And the way they did this is basically they looked at all the stent groups individually, and there were different stent groups within each generation. You have paclitaxel or Cypher, and you have different newer generation stents. A more simpler way would have been to just look at new generation versus old generation. And if you actually look at the interaction by just looking at new generation versus old generation, you have 2 larger groups, and therefore you have more power. And if you do it that way, you actually do find an interaction, meaning the benefit of extending DAPT does vary by the type of stent you implant. So I think it's important to get that message out, because I think the immediate dissemination in the lay press, lay media of the DAPT trial is one of continue DAPT indefinitely because it prevents stent thrombosis, but I think that's a gross oversimplification of the data.
Dr. Latke, what do you think about that analysis?
Yeah, I think that, I don't know the specifics, but it strikes me as being, at a principle level, very good, because I think that my perception of this is that your risk of bleeding is maybe divorced from or independent of your potential benefit on stent thrombosis. So you're paying the same price with the risk of bleeding for a different amount potentially of benefit from preventing a stent thrombosis. So if you can find the group where there's lower risks of stent thrombosis, but you're paying the same price, that's a different risk-benefit balance than the higher risk group. So I think that that's the key thing about the trade-offs that we're saying here. And so in particular individuals, there may be higher risks of bleeding or thrombosis in general as well. So I think all of those things come into play. And if I could make one other comment or statement, we're cardiologists, so we're worried about the heart. So obviously an MI and a stent thrombosis is the worst problem in the world. And, GI bleed or a bleeding problem, that's kind of annoying. And, we should, that's just bleeding. Just give them a little blood.
That's not what I think,
No, no,
as you know.
I'm being a little cartoonish here about it, but, I've been in a lot of studies where we have people from different disciplines. And, you have the GI doctors, and we were on a panel together, and the most important thing for them, the thing that gets them up in the middle of the night, is the GI bleed. And the MI is not something they have to worry about so much. So we have to remember our biases here, that, we're focused on the cardiac endpoints, and the patient, we have to worry about the whole patient. The other thing to say is that there are some data, we have some, it's not yet published, and I've seen it from others, that say in the long term, late bleeds well after the implant, the subsequent mortality risk of a late bleed, one that was bad enough to get you in the hospital, or a spontaneous MI, is about the same. So that's an important observation to say, these are not just kind of annoying ticky-tack little things. These are serious things. So I think the issue, again, is, my theme would be there's a risk balance, benefit and a risk. And the benefit, I think, is there, the risk is there, and that's what makes it complicated, is that it tips at different points and in different patients.
Yeah, no, I think those are really, really good points, and it comes back again, and I'm going to start a series of cases for you guys. I'm going to present real patients with real dilemmas and real issues and ask you each to help me through them. But let me come back to you, Dr. Fuster, because I think the area that I think is extremely important is exactly what Mark Latke just put. And we're doing a lot of these trials, and I know that I see Dr. Halpern in the audience, who sits in so many of these executive committees, and we're constantly thinking about, especially in atrial fibrillation trials and with the new novel anticoagulants, what is more important, this whole weighted composite endpoints. Do you ever think that at some time, Dr. Fuster, that we will get to a point where we actually can say, okay, death is the worst thing that can happen, stroke is probably next, and then have a weighted composite so that we could actually put some kind of a weight, and an important weight, on endpoints, rather than looking at this MACE event as a whole event that looks at a bleed and a death in the same exact fashion and severity. What do you think about that?
I think it's happening. If you compare coronary artery disease with atrial fibrillation, it's something becomes very obvious when you study all the trials. In atrial fibrillation, we are very, very concerned about thromboembolic events, and particularly older you get, more concerned you are, and the bleeding goes down in the scale. Mm-hmm. So whether in coronary artery disease, we are struggling constantly because the number of events is less than in atrial fibrillation thromboembolic. But I'd like to add a point to, I think I'm trying to answer your question, but there's another point here. One thing is the stent, and the other thing is the native disease, and I think we have to separate it in this discussion, because in the stenting, frankly, somebody has to show me the data that you should give the drugs more than a year.
Yeah.
Even the DAP didn't
totally
convince
agree with
me.
you.
However, what I have been doing, and I didn't change, is the patient who has complex disease, regardless of the stent, I continue with two agents. Why? Because I was involved with the Charisma trial. Mm-hmm. In the Charisma trial, the AMI was not an endpoint, so it never came through. It was a secondary endpoint. It was a significant difference in stable coronary disease to give 2 platelet inhibitors versus aspirin alone in the Charisma. And more complex the patient was, higher was the likelihood that the benefit would be more significant with 2 drugs. I use that forever on the patients, whether they have stents or not. The problem I have is when I talk to Dr. Maury about how complex the disease was in the DAPT study, he says there is no difference with the complexity.
Yeah.
Then,
so that,
you say, well, your hypothesis may be incorrect, but this is what I'm doing. I have about 25% of my patients continue forever with 2 drugs, and these are the ones I'm most concerned about, the complexity of the native disease. In the others, I stop for a year, and even I wouldn't have a problem 6 months.
Yeah, I think what your point is well taken, and when we do ask Dr. Maury that question, she used traditional risk factors for stent thrombosis way back when, diabetes, bifurcation lesions, these things, very, very different than what we now know are important risk factors in that paper. So I have a lot of issues about that, especially since in the DAPT study, you would think, though, that the diabetic patient, Dr. Fuster, actually did not get the benefit. There was a P interaction in the wrong direction for the diabetic patients, and I think that's going to yet be a big, big issue, I think, to talk about, because how would you ever imagine that these diabetic patients who have constantly are having these inflammatory biomarkers and thromboembolic disease should not benefit? So something is wrong there, right?
No, but it's in all the diabetic studies. Let me tell you, in the primary prevention, you still have to show me that aspirin
Works.
is a benefit in diabetes. Actually, it's the opposite.
Mm-hmm.
So diabetes has something that, don't ask me what it is.
Yeah,
that
something
really
is with diabetes.
Makes the whole antithrombotic to really go out of scale in terms of common sense.
Mm-hmm.
And this happens on all the diabetic studies. In our
Mm-hmm.
primary prevention with aspirin is gone.
That's
with
right.
the diabetic patients. It's the same what you're saying in these studies. So something, diabetes is very aggressive atherosclerotic disease. I'm not so sure about atherothrombotic disease. At least this is the ways.
Yeah, very, very interesting. So today we talked about the moving target of interventional cardiology and how we feel like our devices are coming forward in a very fast way and that the randomized studies fall behind. Yet Dr. Latke showed us with his big analyses that actually in looking at large databases that you actually didn't find for the hard endpoints that we've changed very much between our revascularization strategies per se. But I come back to say that because of the fact that our technology is evolving, while we want the randomized studies for that hard endpoint of death and MI with 10,000 patients, we can't afford to wait that long to get the answers, Dr. Latke. So we have to rely on meta-analyses. And nowadays, there are more meta-analyses that are really garbage and torture to get through than there are great randomized studies or what have you that we can make important decisions. And then guidelines are using both of these as ways to put together recommendations for clinicians. What should we do? Is it the randomized study that should trump all, everything else should be thrown away? We now have a DAPT study. Or do we have to look at the totality of the evidence, and how do we do that as a clinician? You help us get through that since you have worked so much on this area.
You know, I think it's always the body of evidence, and you know, in science we like to see things replicated. You know, we talk about replication and so on as being important, and then we believe it. Of course, you know, we don't have to see it replicated 47 times before we believe it, but we do want to believe that it's true. So I think the body of evidence is there. And experimental evidence is generally better than purely observational evidence, although there are some limits to experimental evidence because sometimes it's artificial. I actually thought you were going to say that the answer, because the trial was not there, is we had to also make sense out of some of the registry data that we have.
That's right.
As well. And I would say there's a role for that because not everybody was at this talk today, but I think that one of the issues for trials is that they're sort of fixed in time. You know, we take a snapshot of practice at a certain time, but the epidemiology changes, the background therapies are changing, outcomes are changing. So what does that mean? Does that mean that a trial that was a few years older, do we not pay any attention to it? Do we kind of discount it? How do we extract that information? And my contention is that one of the ways to deal with that is maybe by tracking things along in a continuous way by capitalizing on some of our registry data to say, well, okay, here's the outcomes, and if it really is a breakthrough, you know, the trend line, instead of going just nicely along smoothly, should go and, you know, have a hitch in it. Mm-hmm. There ought to be some kind of an obvious break from a breakthrough.
That's right.
And I think we can use this as a complementary way. Now,
So everything is complementary, is what you think that you
complementary
need
to
to
the
put it
trials
together?
and helping us integrate the information together. I think where we are with evidence-based medicine, though, is it's very hard for us to take data from different sources, from epidemiology, from trials, from observational comparisons, and mix them together in some principled way. And I think that maybe is
All
the
right.
challenge for guidelines.
Well, so since we've had this great discussion, and we can go on about the mortality and all of this, and we'll maybe get to it, I want to get to some cases because we have these great things. And Sandeep, since you're now our expert in this area, I'm going to present a case to you, and you're going to have to tell us what to do, and maybe tell Dr. Fuster what to do, and next time he gets to see a patient like this. A 57-year-old gentleman who came in with a fresh STEMI 3 weeks ago, has diabetes, is a smoker, and has an elevated cholesterol with a low HDL, gets discharged home after a stent to the right coronary artery was performed, but also has a non-significant lesion, about 40 to 50% in the circumflex, and in the proximal LAD, there's about a 70% lesion there as well. The patient gets discharged home on aspirin and ticagrelor and is basically asked to come back in about a month for interrogation of the LAD lesion. This morning, let's say it's 3 weeks later, he wakes up, feels nauseated, and begins vomiting frank, fresh blood, and is obviously calls 911 because he gets really, really nervous and is brought to the emergency room. He's tachycardic. He has a blood pressure of 90 over palp, continues to vomit, and on his discharge medication, other than aspirin and ticagrelor, is a oral hypoglycemic, Avandia, and he also takes, he was on Zocor, as well as on a low-dose beta blocker, metoprolol, and an ACE inhibitor. What do we do? What are you going to do?
Well, I think first off, I'll say I never presume to tell Dr. Fuster how to manage patients. It's the other way around. But in this case, I mean,
Good answer.
in this case, I mean, it sounds like we have a high-risk patient with, multiple lesions, one of which was revascularized, who's coming in with a frank bleed. I mean, he's vomiting out blood. I think you have no choice at the time except to hold dual antiplatelet therapy until you've gotten your friends from GI to evaluate the patient in the setting of bleeding.
So the first thing you're going to do is stop, what do you think,
Yeah,
Dr. Sharma? 2 weeks after a STEMI, we've got non-stented vessels, diabetic patients, stop both aspirin and ticagrelor. What do we do? What should you do?
Well, at least the good thing here is this patient on ticagrelor compared to other more longer acting, whether it's a prasugrel or clopidogrel here. But clearly in this situation, till know further how bad the GI bleed is, you have to stop those antiplatelet therapy and of course get the GI workup quickly, and the GI will guide it. They may say that it was a small ulcer, they cauterized it, or it was just erosion. Patient was not taking, many of these patients who are high risk at baseline, we discharge them on proton pump inhibitor. Maybe patient was not on. So maybe some simple the solution to the problem, and then you go ahead and continue. There may be another case which I have actually over the years I have seen. They did an endoscopy and they say patient has a gastric cancer. But what happened? Antiplatelet therapy unmasked it. And I have 3 patients in last 7 years who, after antiplatelet therapy, they come back with some hemoptysis, some hematemesis, and scopes said, cancer localized or. So basically will depend on the endoscopy for the treatment, and when you restart is again based on patient subsequent condition.
So let's say the bleeding is controlled, and anybody can answer this. The bleeding is controlled, the patient is stabilized, we still have and there's a drug-eluting stent in the right coronary. We still have these other lesions to deal with. Are you now thinking a whole separate scenario for this patient, or would you proceed in the exact same direction as you had planned before? You put the patient back on ticagrelor knowing that they still have a higher rate of bleeding with compared, what do you do differently now?
Well, I mean, clearly that yes, that even the ticagrelor trials, if you take to the PCI group with the comparable doses of clopidogrel, will have a slightly higher bleeding. Now, what we learned also with the ticagrelor particularly is that dependence on aspirin, this combo, is less important. That basically means that we have gone down to the dose of aspirin with ticagrelor without really compromising its efficacy, although no study has done, of course, one of the trials which will be working in the future. But the key is, so in that particular case, and maybe the bleeding occurred because more from aspirin rather than ticagrelor. So it could be that many of these patients, we just continue single antiplatelet therapy and don't intervene on the second lesion unless it is necessary. Even if you planned it beforehand, let stomach heal and postpone 3 months or longer. Actually, I just had one patient which happened about 3 weeks ago, supposed to come for stage intervention, came back with GI bleed about 12 days later. He was on clopidogrel anyway, and we postponed it for 4 or 5 months. So clearly that unless your hands are tied because patient was ischemic during this episode, shows ST segment changes, rules in again with some troponin, and so maybe then you want to intervene. But otherwise, the stage intervention should be deferred clinically and may go on single antiplatelet therapy. And I would say if you decide for single antiplatelet therapy, probably the ticagrelor will be the best one.
What do you think about that? That's a wild answer. I like that because we're trying to do that in the Twilight study. I love that. Thank you for that. But Dr. Fuster, what did you think about that? What do you think about withdrawing aspirin in these patients?
Well, first of all, the answer is endoscopist.
Mm-hmm.
If endoscopists tell you it's a single, well, I don't have to repeat what he said,
Right.
but between two drugs, I'm much more concerned with aspirin than with ticagrelor if there is a GI bleeding.
Mm-hmm.
Because aspirin, you bleed with aspirin by 2 reasons. One is the blood is thin, and the other is the ulcer, is caustic to the stomach. Ticagrelor is only the blood.
Mm-hmm.
And I think this is something that I would consider. If you
Any
have
other
to choose
comments from
one.
anybody else? Anybody would do anything differently? Oh, nobody would ever think about
No, I
anything
have a
different.
question. If you are so worried about the bleeding, why you don't go to clopidogrel? It's less potent, has less bleeding, and also works.
That is absolutely correct, but it's the same. I mean, issue comes, this was the patient who had a STEMI recently, and the trials have shown to be beneficial with the ticagrelor, but that was with a combination. Now, if you're going to a single agent, as I mentioned, that even in the Plato trial, the aspirin and clopidogrel combination had a lower bleeding compared to aspirin and ticagrelor. Now, question, if you eliminate aspirin, I would say ticagrelor will have a lower bleeding than aspirin and clopidogrel. And because in that particular case, if I'm giving clopidogrel, I will continue aspirin. And the idea is in this case scenario, if we can come out of the aspirin, we'll be ahead of the game.
I just want to
Usman?
just to bring up following Dr. Sharma is saying we give the reason we're giving aspirin is because of the key landmark trials of the late 90s, early 2000s when stenting was first being done with balloon angioplasty and bare metal stents, and the background therapy was aspirin, and then iterative trials, just like in ACS, whatever the background therapy is, we build on top of that. And it's only recently we're beginning to challenge that paradigm, and the WUS trial was the first one to actually challenge that paradigm. There are very limited data, but there are data trying to look at thrombotic events in patients treated with dual antiplatelet therapy to see are those events primarily occurring in patients who are off aspirin, yet they're on the thienopyridine, or are they coming on patients who are off the thienopyridine while still staying on aspirin? And it's a tough thing to get at, but it's something we're also looking at in the Paris registry, and what it looks like basically is withdrawal of aspirin. As long as you have a background thienopyridine, the risk of taking aspirin off is quite low. This has to be proven in randomized studies. The reason it hasn't been done is because aspirin is always a background therapy, but there are intriguing observational data sets out there that do suggest that the harm of taking off aspirin, as long as you got the thienopyridine on the background, is extremely small. The risk from a thrombotic standpoint occurs when you drop the thienopyridine. And so that's, exactly what Dr. Sharma is saying, and, we need randomized data to confirm that, but
Now
But-
we're gonna
but
taking on
what I
it.
say is, I agree to suppress aspirin, simply that the patient that you presented is very high bleeder. So, and why you have this, because we know that in the Capri, clopidogrel was
Better.
better than aspirin
Yep.
and with less bleeding. So,
Right.
because in that case, you are more worried about the bleeding. That
So the next case is a real case as well.
Can I tell
Yes.
one?
Yes,
In a myocardial infarction, it would be questioned, the use of clopidogrel
alone.
alone. I'm just telling, this is a critical issue.
No, but this guy is already treated. So the problem with Emma is when you start with clopidogrel with the 75 milligrams a day, but this person has been already in ticagrelor. Because remember, in the moment that you give the loading doses, but again, this is my opinion, I am not going to tell you how to treat your patients, okay?
That's right, never. Let's go to the next patient, which is a common problem. 75-year-old woman, this is very simple. A month after a drug-eluting stent, 3 drug-eluting stents, 1 to the right coronary and 2 in the left anterior descending artery, has a hip fracture, displaced hip fracture. Dr. Dunsky, what do we do?
Call Dr. Peters. We'll figure it out.
Has a hip fracture, the orthopedic surgeons, or this is a month after a DES, and these are Zion stents in 2 arteries. The patient is totally fine, no symptoms at all cardiac-wise, but has to go to the OR for a displaced hip fracture. What do you do?
Well, the first thing, obviously, you speak to your orthopedic colleague, right? And I think that in seeing what they'll do, clearly in terms of what their bleeding risk and where things are. If they say, clearly the patient has to get the hip fixed, because the mortality of that is
That's right.
through the roof. So the hip has to get fixed. So from my standpoint, it's a conversation with the orthopedic colleague. If they would operate in this setting within the month of time on the antiplatelet, I would proceed that way.
So you'd keep the patient
I
on
would.
dual antiplatelet therapies. Does anybody dare to take the patient off? Dr. Sharma? This is a big operation. They're gonna be putting in rods and, they don't like to operate on dual antiplatelet. And this is aspirin clopidogrel. It's not ticagrelor or prasugrel.
Well, that actually, even before the orthopedic anesthesia cancels the case. Not even question. They won't even ask the cardiologist. You figure it out later. But yes, this is a very important problem. Now, I can just say that some data we have, there is a trial called Zions v. USA. Run of the mill, all similar kind of patients. We did a 5,000 patient study. And then about 10% of those patients, of the 5,000, require discontinuation of antiplatelet therapy for surgery. And it turns out to be that if you have simple lesion, and simple lesion they define non-bifurcation, large vessel, non in the vein graft, non-MI setting, that after 1 month, in about 300 patients, they withdrew, they discontinued the DAPT, nothing happened. If you are complex case, multiple stents, vein graft, post-MI, that after 3 months, and maximum up to 6 months, about 220, so about 5% of patients, 4 or 5% of patients, they stop DAPT after the 3 to 6 months. So it seems to be that once you go through the 6-month period, you are safe. But in this particular case, you can go beyond because your patient happened within 1 month. So now question is what to deal with it, how to deal with that. We know that antithrombotic therapies, heparin, which we used to use in the beginning, do provide some benefit. And surgeons will definitely cancel, and anesthesia will cancel this case on the dual antiplatelet. You can convince them to continue one, and usually they are okay with aspirin, but not with your PTY12 inhibitor. So in that particular case, patient clearly hip fracture can wait 2-3 days. You take off after 3 to 4 days activity of the agent, which you can also sometime monitor by the PRU activity testing that maybe it's not working. PRU is more than 230. But having said that, the question then comes is that what to do in this case. If it is a simple case, was a mid-LED, OM, non-MI situation, I would say that based on the available data and personal experience, and it's about a month, you can let the patient go on aspirin only. If it was a bifurcation stent, was a left main stent, now has a hip fracture, our policy has been that you stop, of course, the Plavix in this particular case, but it start on heparin, again anecdotal. Some people actually give 2B3A inhibitor for that 2-3 days period before patient goes for surgery, short acting, like either tirofiban or eptifibatide, and stop it 6 hours before the surgery. So the various permutation and combination. We actually have written with the paper with Jason and the 2 other papers in terms of what is the best approach. In this particular case, what we will say based on the simple case, simple lesion, second generation stent, EES, our Zions, after 1 month, you can get the patient surgery only on aspirin. If it's more complex, then you give a tie-over patient bridge with the IV or subcutaneous heparin. Soon we'll have another agent, which is the IV cangrelor, will be a great agent for this purpose.
This is the place where the bridging with cangrelor could be very helpful. Would you agree, Dr. Fuster?
Completely. I
In
think,
here, this is
actually,
the one place.
Orthopedic people fix the hips with aspirin.
Mm-hmm,
It's not a problem.
mm-hmm.
And I think
Mark,
we take a compromise.
any comments on that? Would you do anything differently than our clinical experts here?
No, I couldn't help reflect, listening to this, is sort of this you know, the limits of evidence-based medicine when you come down
Exactly,
to,
and we're going to go to that.
to these, you know, it's like, where's the trial of 10,000 people who had a hip fracture?
Exactly.
You know, we're never going to have those sorts of things, and, you know, I think that the main thing, and this is why my emphasis on generally on the trials, is to try and get the insight out of them, not necessarily the answer. You know, what is exactly going on here? Because then we can apply that in situations where we're kind of away from all the, you know, in these situations, what is the thing we really need to keep our eye on, and what's the main issue there? And I like the reasoning here about what we're trying to do, and which thing is posing the
So the
greatest
art
risk
of
to the
medicine
patient.
still
Yeah.
stands alive. So Dr. Sharma, when was the last time you saw an acute a stent thrombosis case in your lab here?
Yeah, actually, you know, the one we had, if we take in 2014, 3 cases of stent thrombosis after discontinuation of therapy of clopidogrel, although many of them continue.
3 out of a denominator, because
No, but
Dr.
this is-
Latke
but
needs
all
to
of
know the
them-
denominator.
The point I want to make it, all 3 still were Texas and Cipher. None of them were second generation, which means these stents were placed 6-7 years ago. And for some reason never endothelialized, they continued on antiplatelet therapy, and now stopped it for the purpose and came back. So we still have to see a patient with the Zions is developing stent thrombosis, was placed out 1 year ago or 2 years ago. So very extremely rare with the newer generation
So
stent.
Dr. Fuster, what do you think is going on here with these first generation? You think there's neoatherosclerosis, a ruptured plaque inside of the stents? What is happening here in the early generation DES, and you think that we'll see it with the Zion stent?
No, well, the question of thrombosis, the first generation is much more complex, the device in itself. And you have a surface which is much more irregular and much more exposed. With the new generation, these polymers go away and they get much thinner, and I suspect less prothrombotic. I really feel is a mechanical and a chemical difference between the stents. Actually, that's how part of the newest stents gets related to the thrombogenicity, by the way I'm describing.
Yes, so this is really important. Before I go to the last case, yes, go
I
ahead.
have a question for you, though. About the trials, you see, the problem that we have is when we see many patients, we realize that are so many that there's no trial. In other words, I would say to you, in my life as a physician, looking at complexity, maybe 75% of the time I have to make a decision that has nothing to do with any trial, because the comorbidities that the patient presents
This is the
are
problem.
so wide that you cannot just, what I'm saying is we constantly say trial, and this will be a trial. Yes, trial, but every patient presents with 7 things that should have a trial. And the problem, and just the concept, that we are
It's
very
such
obsessed
a,
about.
you need to write that in your jacket. We need an editor-in-chief's note about clinical trials, because I really do believe the DAPT study screened 26,000 patients. to find 9,900 of them to randomize in the pool. So it is a fraction of the real world population, and that's why the registries and these other data are so very, very complementary to the randomized studies, and we shouldn't get rid of those. But before we open this up to everybody, I want to come to the most difficult patient. The patient with chronic non-valvular atrial fibrillation who now has an LAD lesion that requires a stent. If you ask 9 cardiologists, they will give you 9 different answers. We have 1, 2, 3, 4, 5, 6, 7 cardiologists, basic science, what have you. I want to hope.
Excuse me, the guidelines just came out and give you the answer.
Yeah, well, so but is that really the answer? And the question is, especially with the novel anticoagulants, and especially now with the novel anticoagulants, this becomes, and what is the duration? And I know this audience and everybody who's there in the online and in the virtual world wants to know what all of us think here and what we do. So should we start with Dr. Fuster, or should we have him go last, or should we start with Kevin? Kevin, why don't we go with you? Tell me what you do, just quickly regimented, 2 minutes, no more than that.
Essentially, triple
1 minute.
Triple therapy for a month, and then I would stop the aspirin.
Triple therapy for a month, you stop the aspirin, and if it's a novel anticoagulant, the same way. Triple therapy, you don't change it if it's Coumadin or not. Okay. Okay, Sandeep.
Yeah, I agree with Dr. Dunsky. I mean, triple therapy for 1 month, novel anticoagulant, and stop the aspirin.
Incredible. Stop the aspirin. Okay. Usman.
It's a stable patient, straightforward lesion. I would use one, and the patient can take a novel oral anticoagulant. I would use one of those plus clopidogrel, and that's it.
No aspirin,
No.
even from the get-go.
No.
Mark Latke or Juan, what do you think about that? Do you think you think he's risky? I know you're not, but what do you think? Is that risky?
Again, if I was the patient,
Pathobiologically?
I will take a novel oral anticoagulant, and for the hot phase, that the question is whether it's 3 months or 6 months, I will take, if I don't bleed, triple therapy. If I bleed, I will cut aspirin because
If you bleed, it's too late already.
No, but I prefer
Don't
to
want
prevent
you
my
to bleed.
brain
The
versus my
question
heart.
is to prevent you from bleeding. Dr. Latke.
You know, I'd say that the biggest thing to me is among these things that the endpoint that we're trying to prevent that means much more to people is the stroke rather than the MI or the bleed. And even opposed to what you were saying, that there's some people who would think that that's actually a worse fate than death to have a disabling stroke. So I think we need to keep our eye on the ball on which things are the most important. So the key thing I think would be to make sure that we have the anticoagulation. And I don't know if there's data, but I would tend to agree with the idea that either very short for the triple or even just going the aspirin, as Dr. Fuster's point is not just is causing some problems with the bleeding, so GI bleeding. So I would just say our focus really is on the stroke rather than the MI.
Dr.
Well, I mean,
Sharma.
clearly the WHOOS trial did show that you can drop the aspirin right from the beginning. I know some people believe in the 1 month, and I can tell you 3 years ago we did. And if I recall, clinically evident stent thrombosis in last 4 years, I had one. And that patient had a double vessel stenting of the LAD and RCA, was on AFib, and we discharged the patient on Plavix and Coumadin. Patient developed stent thrombosis day 8, lived in Brooklyn, went to a hospital, local hospital, could not be resuscitated. So clearly that yes, whatever you learn from the trial, you try to applying it, it's just again, you have this kind of case really anecdotal. So what our policy has been in our cath lab at present, that if patient is on warfarin, that 1 month of aspirin and continue, triple therapy for 1 month and then drop the aspirin after 1 month. Now, question gets more complicated with the novel anticoagulants, and we actually part of, there are few trials answering that question. We are part of it, one of them, Pioneer AFib. The problem with the Pioneer AFib is if you ever have a TIA or CVA, is exclusion. So we could have randomized many more patients in this. in the trial. But anytime the CVA, TIA, even TIA, ever, the patient could not be part of it. But that probably will give the answer of various combination strategy, but try to avoid the novel anticoagulation to start with. If they are already on, then same rule apply of 1 month of aspirin and otherwise just 2 therapies thereafter.
Dr. Fuster?
Yeah, I frankly use 2 from the beginning, which is warfarin, if it is warfarin, and clopidogrel, which is actually in the guidelines of atrial fibrillation that they suggest. I think it's based on the West study. On the other hand, if there is a new antithrombotic on board, this is a tough one. It's tough because we don't know.
You enroll them in a trial, right? That's the
Yeah,
real
well,
right answer.
I mean, I would
We
use-
certainly can do that
I
here
would-
at Mount
I
Sinai.
would use the same strategy, but I must say the data is much weaker. That's all I can
So
say.
can I ask
But
Dr.
just to add on to
Halpern,
that point
because
also, that with the newer anticoag, in this group of patients, you try to avoid your more potent antiplatelet therapy.
Yeah.
right,
So not a
certainly no
ticagrelor
ticagrelor
and not a
or
prasugrel.
prasugrel, right? That's a no-no in the European Society of Guidelines. Dr. Halpern, it's wonderful to have you. What do you think? What do you do, and what do you think about this whole area?
I don't have any more information than anyone else does, and I think the general tendency today is to drop aspirin relatively early. There is this concern about greater bleeding with clopidogrel plus an anticoagulant versus aspirin plus an anticoagulant, but this really has not been well looked at. In a place like Mount Sinai, the thing to do is put the patient in a trial.
I think it's a two-way
Put the patient in.
on the recent guidelines to do that. Yeah.
Well, this has been an incredible session. Thank you all for your contributions. Dr. Latke, wonderful to have you, knowing everything that you know and shedding more light into the clinical studies. And Dr. Fuster, as always, telling us that now the art of medicine is most important, then that's why we all look up to you and admire your bedside practice of medicine. Let's open this up now to anybody who wants to ask any questions. Dr. Sandy Friedman. Wait for the microphone because we're online and the world wants to hear your questions.
The microphone. So, I'd like to know in your practices, after 1 year of dual antiplatelet therapy, are there any clinical or angiographic features that would want to make you continue to adapt beyond the 1 year? Do you have patients where you think because of anatomy or lipids or whatever that you really would feel more comfortable continuing beyond a year?
Okay, well, I mean, clearly the cases would be the same which are really high thrombotic risk, which we are, even before the DAP trial, we are continuing longer. And many of the classical example will be the patient post-bypass. We have done intervention, has come back a couple of times with the restenosis or a new event. Those patients will be reasonable to continue longer. Bifurcating left lesion with a left main lesion, patient with a severe LV dysfunction, and critically important vessel intervention. So those cases, even knowing that those were not the part of any of these randomized trials, because randomized trial purposefully have excluded. If you see the event rate in these randomized trials, it's 3 or 4% at 6 months or 1 year, because they're low risk group. So once you get to those high risk, I think even before the DAPT or post DAPT, we are continuing those antiplatelet therapy longer period of time, whether it's 3 years or
Even
less.
myocardial infarction, if you're asking my opinion. I think 25% of the patients that we see with the stenting is acute myocardial infarction, and this patient to me is a high risk.
Anyone else? Any other questions? Well, thank you all for being here, and thank you to the fantastic panel and Dr. Latke.
This is a great format.